Excellent. So first of all, thank you for joining us here. It's great to have input from all of you. That's what makes this meeting so special and will make it worthwhile. I'll just skip through this quickly and try and take you through my journey with the ACL internal brace. It's been a colourful journey, and I've been on it with most of you in this room. Actually, you've shared this journey. So I started about kicking a football and spending a lot of time in a treatment room, and then we've been taking some of that information with us. But you might recognise yourself somewhere amongst this collage, but it's really been the people who have been on the journey with me that has made it so special. But I think we're at a wee point of reflection, and this is probably the most famous Scottish surgeon from Glasgow. He was a surgical innovator and worked with Lister and learned about antisepsis. And he realised that this could be applied to all aspects of surgical practice. But in Glasgow Royal Infirmary, they refused to allow him to boil these instruments. They said, for 1,500 years, we've known that pus is essential for healing because every wound gets infected. So ideas are slow to change, but this was his summary at the end of a rather impressive career. Does it remember that your textbook is just a scrapbook of the guys that went before? You should ask questions. But anyway, McEwen went on to do all this. He was a founding father of orthopedics, invented the osteotome, took out 500 kids with rickets in Glasgow who would have died of sepsis, operated on them all, and nobody died of sepsis. So very bold in its time, but he believed in what he was doing. So I'm delighted we've now got this internal brace international study group, and it's growing, and it will hopefully be adding one or two of our prominent speakers today. But we're at a point in surgical history where I think we can do things differently. This is always a disturbing slide, especially as an ex-footballer, that the arthritic knee in a young man, although one of my nurses said, that can't happen to me, you're no longer a young man. And she was quite right. But we should always remember about the beauty of the anatomy, and we should respect this. And it's not just the vascularity, it's bone and soft tissue. Art's my hobby, and you always have a choice, and you can repair or you can reconstruct. Now, at one point in history, it was clear that repair, as John Fagan had described, was not particularly successful. The techniques were primitive, and we moved. It was a sliding doors moment, and we moved in the direction of reconstruction. But those guys involved at the start 50 years ago understood it was a compromise. And the reason it was a compromise is everything would get weaker because essentially it was dead tissue that had to become living tissue. And it must contribute to the arthritic process because there's so much bone destruction as well as impacting of dead tissue. So it's an interesting thing is if you follow the history of ACL surgery, everything's been tried, okay? But the revision rates have stayed high, disappointingly high, and all these options have been explored. Even aspects of fixation and some of the excellent fixation we have, like the tightrope, it still had concerns. So we came at it slightly differently. As you heard from Tom, we started in the Stedman Clinic. It was a fantastic opportunity to pull minds together. John Fagan, on the right of me there, a fantastic guy, unfortunately now passed away, but he did the West Point study saying that ACLs couldn't heal. When I spoke to him, he said, you must try this. I said, but John, it was your research that everyone keeps quoting to me. And he said, but nobody understood my research. I said, sorry? He said, nobody understood. I said, what do you mean by that? He said, well, a third of these healed and they got back to sport and a good, stable function. He said, our techniques were hopeless. We filleted the knee open, we put them in a cast for 12 weeks. He said, I was amazed that anyone healed. He said, you've got to revisit it. And the following weekend, I did my son's best friend who ruptured his ACL playing rugby. And that was the start of this journey. So we had to figure out how to do it, first of all, and to make it biomimetic. It was important that we didn't try to recreate anatomy. Oh my goodness. Now, nobody sleeps through one of my presentations. But the point was at the start, everyone would say, well, where is the science? We had to go through the translational research, and it was appropriate we did, okay? Orthopedic opinion is like an oil tanker. It turns very, very slowly, and they wait for evidence and wait for evidence, even if they know there are lots of problems. So we've been doing this. We're looking at techniques and applications of the internal brace. We've allowed the evidence and technology to gather and mount as we move forward. It's initially a slow process, but it gathers its own momentum. And you can see here, we'll just rapidly fire through some of this, and it keeps growing, and it keeps growing. It's been confused in the literature a little because some journals will not allow to describe the internal bracing technique. The internal bracing technique is not the same as suture augmentation. If a suture is incorporated into the graft, it often will weaken the structure rather than enhance it. The biomechanics are undermined. It's a crucial point, but it's actually been a problem in literature. It's creating confusion for surgeons. But we've now got, as part of this process, over 1,000 papers in peer-reviewed journals. But we started out looking at the technique, and as Wayme showed so beautifully there, it's a lovely thing repairing an ACL. I mean, it's so delicate. You tiptoe in and you tiptoe out, and patients feel great, okay? And then we can simply, this was the original technique, we were really keen not to strangle the biology because the vascularity is essential for healing. And this is a really good point now that we're moving forward, that the knotless system has to be used carefully. It gives you an excellent hold of the soft tissue, but you can't strangle the biology. But the principle of the internal bracing technique is straightforward. We've always realized that there is this tipping point, yield point, and that's where the internal brace should kick in. The biomechanical studies were fantastic early on. I remember saying to Reinhold, I don't think any other paper will have as much impact or has had as much impact in the last 10 years because we realized at this point that we could significantly improve the strength with an internal bracing technique in parallel, not incorporated within, but in parallel. And it could be applied to any graft. It's a really important aspect. You'll recognize many of the individuals in the room. This is not a solo effort by any means. This is a teamwork. Adrian had been working, and actually it seems to get forgotten these days, but was working all inside ACL, I think it's fair to say, Adrian, and suture augmentation, looking at how we can augment it. But what we realized was the biomechanics here worked perfectly. Either through good luck or design, it dramatically improved the performance. So all of our results are now with much smaller grafts if we need to use a graft because of this research. And it doesn't matter whether it's hamstring, quadriceps, or patellar tendon. Our early results, a bit like Wayme, we found that our younger patients were at slightly higher risk, but overall our function was very good. And if the red ones, for example, that did fail, you get excellent results if you had to go on and do a standard reconstruction. But the red, as we can see here, are the young patients. So we had to understand more. So Wayme said, patient selection, absolutely crucial. We can pick the winners. But when you do pick the winners, it's a beautiful thing, okay? Function is so much better. And this is an Olympic swimmer who ruptured her cruciate ligament just before the last Olympics, Kathleen Dawson. The function at 7 weeks following surgery is remarkable. And it shows how, if we respect biology, we can do this differently. She actually went on, it was the only option, that's why they came to me effectively for ACL repair, because she didn't have time prior to the Olympics. But she got a personal best in the Olympics. She won a silver medal, and what is interesting, she just qualified for the Olympics in Paris 4 years on with a stable, normal knee, a forgotten pathology with a healthy joint. So ACL repair and internal brace in appropriate cases is ideal. On the left, we can see how the technique has evolved using the tightrope and fiber rings, but it's essentially the internal brace that's transformed the outcomes and the results, the internal bracing technique. And this goes for all the applications in the body. We have to respect the principles of the technique, and if we do, we can reap all the benefits that come with early intervention and repair in appropriate cases, protecting meniscus, proprioception, etc. So we realized that in about 2014 that the ALL was becoming topical, and it seemed a very small step to add an internal brace to the ALL, especially when people like Sonri Kotri were saying in ACL injuries, the anterolateral capsule was injured in 87% of the time. So we did this little study, and we realized that our results got better. So wait a minute, we're now doing a repair with a simple add-on that takes 10 minutes and our results are getting better. Now this hasn't become standard practice, but I promise this is going to be the best gift I can give any knee surgeon, is this simple technique. But regardless of what you choose, or which graft you choose, the internal bracing technique will indeed protect it. And we've found that over the last 15 years. So what are the benefits now for those that wish to reconstruct, which is the majority of cases? We can modify the gold standard. We can use a smaller graft. We can minimize the morbidity. We can retain the normal tissues with proprioception and vascularity. And more enhanced products are coming out where the internal brace can protect these various applications. So for all of these applications, the internal brace will ensure that protection that provides for an accelerated recovery and improved outcome. So innovation in technology is changing practice. What does it mean to the patient? This is just a professional footballer, only an 8mm patellar tendon graft, but internally braced. And you can see that in terms of function, it's very good. We probably can bring back a wee bit of the volume, but it doesn't matter. It's okay. That's fine. So we're not quite, we're at 3 months now, and he's back in the pitch, sport-specific training. We're doing it with confidence. This is not taking a chance or a risk. This is normal rehabilitation. He was never that fast. And anyway, back playing against Celtic. So our most recent study, I'm delighted to report at 5 years, because we're getting longer studies, longer outcomes with reduced size graft, augmented with the internal brace, without adding the anterolateral ligament, which we know enhances our results. We've now got a re-rupture rate of 1.1%. Now, we can all talk about failure rates. You know, Australian studies of thousands of patients with hamstring reconstructions, 15% re-rupture rate, 10% re-rupture rate, or higher. It's not unusual. But this is a great slide that Hedy put together, because these are individuals, these are your patients. So, you know, 1.1% profoundly changes outcome. I also think I should acknowledge this, because John Fagan would have been delighted to know that a wee consensus statement that the modern orthopedic surgeon should always consider ACL repair as an option for these patients. So there's a bold man himself. He loved coming to Scotland. We published this editorial recently, unfortunately still getting a bit of a backlash, but we feel that we have an evidence base to support this. And now we've got to ask the question, why would you not protect your graft or reconstruction? Whether it's a reconstruction or a repair, why would you explain to your patient, with the evidence we have, why you would not protect their graft? That's for the individual surgeon to decide. So it's great to show you success stories with the internal brace. That's easy. You know, we've had a great journey. We enjoy the success. But this is my take-home message, that really, this is for everyone. You're a obese patient, you're diabetic. Immobilization is not good for anybody. It's not your high-performance sportsman. It's for all grafts, repairs and reconstructions. So just to conclude, and I couldn't think of a catchy way of pulling this together, but this is my conclusion after 15 years for ACL. ACL stability is about ACL plus IB squared. Thank you very much.